Hi, everybody. I'm here with Dr. Renaud Bollens. He's based in Belgium, and he also works in France and also in Dubai. So I'm Dr. Payares. We're going to have a small talk about what he does. Very nice having you here, Dr. Bollens.
It's a great pleasure for me.
All right. So Dr. Bollens is an expert in pelvic pain syndrome. He is an expert in pudendal nerve decompression and other not minimal invasive approaches. So Dr. Bollens, I would like to ask you, as an expert in laparoscopic and robotic surgery, specifically in pudendal nerve compression, which patient would you say that's the most suitable patient for pudendal nerve decompression? Do you think there's a specific profile and indications? I mean, when do you prefer the minimal invasive surgery over non-invasive procedures or treatments?
Well, I think that as for all the functional problem, is the patient who has to decide. And I say always to my patients, it's like in the Chinese restaurant, I show you the menu, but after you have to decide what you have what you want to eat. And I think that, of course, logically, the first approach is to try to decompress the nerve in a conservative manner. Because, of course, if we understand the mechanism of the compression, we can target some point of the problem to try to solve without surgery the symptoms of the patients. And basically, we target the piriformis muscle with the dynamic part of the compression, because of course, when you have the fibrosis of the ligament, with another part of the problem, we cannot change the fibrosis, but we can change the tension in the muscle. And we try to relax the muscle, and for that, we remove from the environment all the risk factor of compression and of contraction of this muscle. It means we have to avoid the sport activity, who will increase the tonus of the buttock. That's classically a mistake of the patients. We also control the postural issue, because when your bone pelvis is not well balanced, you have the contraction of this piriformis muscle who appears and will be responsible of the pudendal nerve symptoms in the second time. And we can also do Botox injection inside the muscle. And of course, we had a stretching exercise to try to release completely the tension of the muscle. One other thing that we can do is to propose the tadalafil, because the tadalafil increases the flow in the pudendal artery. And if the pudendal artery gives the oxygen to the nerve, it means that in 50% of the cases, the patients feel an improvement when they take the tadalafil. Also in the woman, because of course the tadalafil is usually used by the man, but it works also in the woman who suffer from pudendal nerve. Then this is the first line of conservative decompressive treatment. If it doesn't work, the best option is probably to be operated. Of course, the question is also what is the timing of the surgery? In which moment we have to go? It became urgent to go to the surgery. I think that is the nocturnal symptoms, because the majority of the patient doesn't have symptoms during the night. And it means that during the 24 hours, the patients have some moment of recovery of the nerve. When the patients start to have the symptoms during the night, it means that we start to have a urgent situation who need to be decompressed quickly. That's my opinion. But of course, my goal is to explain to the patient, and after they have to decide what they want. Some of them are scary about the surgery, because the surgery is also a long run for the patients. It's easy to release the nerve, but after we have to inform the patients that they can have a transitory worsening of the symptoms. I have 3 patients who tried to commit a suicide during the first month due to the acute pain and the fact that they feel like if they were in the endless story. But we have to give the good information to the patients. That's very important. And you need to follow the patients to support them during the first year, because the final results is also between 6 months and 2 years. And when the nerve is released, we have to wait, and we can do nothing more. And that's also an information important to explain to the patients. But basically, it's always the patients who told me, I'm ready to be operated.
Absolutely. And Dr. Bollens gave a very interesting talk about this. And we saw that you explained a lot of clinical criteria. And would you rely also on imaging studies? Why yes or why not?
Well, I say always the patients are not crazy. Then when they arrive with symptoms, they don't invent the symptoms. Then it's important to take the time to discuss with the patients, because this syndrome, because we can speak about the syndrome because it is an addition of many different symptoms. This syndrome is characterized by urological symptoms, but also sexual disorder and also anorectal disorder. And when you know that, we can cover with just the anamnesis a large range of symptoms who will give us the idea and the diagnosis of the pudendal nerve entrapment, with, of course, some symptoms who are more specific than the other one. For example, the location of the pain. If somebody has pain in the penis or the gland, in the gland of the penis, the clitoris, the entrance of the vagina, or in the urethra, these three territories are specific from the pudendal nerve. That's an example, but you have other symptoms like the premature ejaculation or the arousal syndrome, which is the equivalent in the woman, are very specific to the pudendal nerve. And this is some symptoms with the experience who, instead to be with a low significance, is really specific. Like the patients who suffer from chronic prostatitis, somebody arrived with, in my consultation with this diagnosis, I know that it's a pudendal nerve entrapment.
When to go transperitoneal and when to go transgluteal?
That's a very good question. In fact, it's always interesting to see the history and the evolution of the technique, to understand finally what is the aiming behind. And of course, the first technique was developed by Tibet Erdoğu. It was transperitoneal approach. This is the first surgery, and we have a good result, like 80-85% of success, but we have still a subgroup of patients without very good results. And I say always the most interesting patients is not the patient who goes well, it's the patient who's still in trouble, because it means that we missed something and we need to continue to search. And what we realize, it's a part of the symptoms of these patients were not related with the pudendal nerve. It was related with the piriformis muscles contracture. Because when we cut the ligament, after a few weeks, the body tried to repair the ligaments. Then instead to have a sciatic ligament, we have a fibrotic tissue, but with the same effect. If under you have the muscle who is still overcontract, it will push on the fibrotic tissue instead to push on the sciatic ligament, but the result will be the same. And also, if the patient had a part of the pain who is related with the muscle tension, when you cut the ligament, you don't change the muscle tension. Then some of the patients have a very big pain with the impossibility to be sit, just because the muscle was under tension. Then we start to think about maybe you have to target the piriformis muscle, and we are not the first one, because the classical technique is open technique to catch the tendinous of the muscle at the level of the trochanter. But the problem is when you cut there, you don't have a control about the position of the sciatic nerve, who can be sometimes inside the piriformis muscle. And if you cut blindly there, you can have a retraction of the muscle, will attract the sciatic nerve, and then after you have a very big sciatic pain. It's the reason why, again, we have developed a minimal invasive, it's just through small incision in the buttock, and you have a direct vision control about the position of the piriformis muscle. Then, of course, the first impression that we have was 80% of success with the piriformis. But we have a bias because we propose this surgery in the subgroup of patients with a failure of the first one. Then it means that we have 80% with patients already operate from the other side. Then they have a double decompression. When we start directly with the piriformis muscle section, maybe the result is not so good. Then we will need to wait more and to have more experience and feedback with our patients to define which patient's profile will be better to start with one or the other surgery.
One last question. What were the main challenges you faced when you were developing your transgluteal technique?
The first problem is nobody goes there.
Yes.
The first problem was to study, to understand the anatomy, and to accept to do a research in the research surgery in the patients. It's always a point of discussion that we have, and I remember that my first patients that I operate, I told him I never do that before, but he told me, I trust you, we go. And he was completely cured, and he was very happy. And the first case was not just to cut the piriformis, it was to remove the piriformis muscle, which was a bigger issue. And finally, the interest to remove endoscopically was a little bit limited, because we have to do a bigger incision just to remove the muscle at the end, that you lose a little bit. We lose a little bit the advantage of this surgery. It's the reason why we are modifying the technique, and still now we continue to change some details. For example, at the beginning, we just cut the muscle, but we realized that the volume of the muscle is not modified when we just cut. And actually what we do, we try to find always the nerves and the vessels from the muscle to denervate the muscle, to create an amyotrophy of the muscle itself. And it's still in evaluation, and it's also the reason why it's so important to have the feedback and to continue to follow the patients, to know exactly we do something, what's happened after, and to stay with the same idea. Maybe it's possible to do better.
Very interesting. Thank you very much, Dr. Bollens, for being here. So glad to have you here.
You are welcome.